All right. Well, thank you, Sandra, for the introduction, and thank you, everybody, for joining on a Saturday morning. So, with that, I'll put everything up. I have left plenty of time at the end of the presentation to go over questions that anyone may have. But if you want to put them in the chat too, if that's easier to remind yourself, we can kind of go through those as well. But I won't be able to see them as I'm talking. So for those of you that don't know me, I'm over at Children's Hospital Los Angeles, which is in East Hollywood. We have a Down syndrome neurology program there that focuses on regression, but we also see patients with epilepsy, seizure disorders, stroke, autism, pretty much anything under the sun. And as Sandra mentioned, we are at a children's hospital, but because there's not other resources for people with Down syndrome who are older, we also see patients up to 50 and can help out with that. We can't always order the same tests at the Children's Hospital. We can help facilitate getting people in from that standpoint. So today we'll focus on regression. Again, this is a new emerging topic. I feel like every time we give a discussion or give a talk on this, it changes. And we are going to have an in-person or virtual symposium at the Children's Hospital on September 20th. I'll include a link to that at the end of the presentation, but that'll be a lot of fun because you can hear from me, you can meet all of the other experts in Down syndrome regression disorder, meet our research team, so it'll be a fun day, snacks, and we'll have a little bit of a reception afterwards as well. So with that, we can jump straight into the presentation. So when we're talking about regression, regression can mean a lot of things. So really, we're using a very broad operational term, and it just says really loss of any previously acquired developmental skill. So this can be language, it could be activities of daily living, like dressing yourself, going to the bathroom independently, eating independently. It can be in communication, it can be in motor function, or even social interaction. So we use a very broad definition for that, but regression can be caused by many things. And really, our job as doctors is to help figure out what is the actual cause of the regression. If we go in the medical literature, we don't really understand how frequent regression is in people with Down syndrome. So in the literature, it used to be called early onset Alzheimer's disease or late onset autism. So we don't really have a good sense of what percentage of people with Down syndrome will experience this, but we think it's relatively rare. It's probably less than 1 to 2% of all people with Down syndrome will experience this. So while we're going to be talking about very scary symptoms at times today, chances are you'll never have to encounter this. Operationally, we talk about people who are 10 to 30 years old, but we've definitely seen younger patients and older patients who have developed this syndrome as well. As I mentioned, there can be many different causes for regression, and traditionally this was thought to be psychiatric. So for almost 80 years, we thought that Down syndrome regression disorder was a psychiatric disease, that there was really no treatment for it. And what I'm hopeful to show to you today is that actually there are treatments for it, and they work really, really well. The timing matters though. So when we're talking about this regression, it's not years of symptoms. It's really acute. So it's days to weeks where all of a sudden you have your happy loved one who's kind of cruising along, and then they kind of fall off this proverbial cliff from a symptom standpoint. And when we're looking at all of the possible explanations for regression, some of it can be normal things that we experience, right? Stress, death of a loved one, moving houses, moving school districts, getting bullied at school. All of these things can mimic regression. You can have hormone problems. The thyroid is often abnormal in people with Down syndrome, and if it's really, really low, it can mimic some of those symptoms as well. There could be nutritional, environmental, pain, even psychiatric causes. But what we've realized over time is that regression actually may be an immune disorder of the brain, and we'll get to some of that in the presentation today. Let's focus on the symptoms first. This is kind of a laundry list. So I include this and then we'll show some videos, which some families have been very gracious to donate videos of their loved one, which help us understand what the symptoms can look like. But the first core symptom set is confusion, disorientation. Sometimes these individuals will be sitting up laughing all night long, but there's not really anything going on. They're just kind of laughing to themselves. They're off in their own world. I think the one thing that we can always say about people with Down syndrome is they love to talk about the things that they're interested in or do the things that they're interested in. And this is kind of a break from that, where they're just kind of staring out the window or sitting in the living room, not even watching TV sometimes. Sometimes we'll see increased eating, often we'll see decreased eating, so almost anorexia. You'll put the food in front of the individual and they'll just sit there for hours at a time, not doing anything. We see that there's also apathy or a lack of interest in doing things. So even though you may say, "Hey, we're going to Disneyland," nothing happens. It's like another day for them, whereas that may have been previously very motivating. We also see that there's memory impairment and there can be difficulty with recall. Some of this is just language, but sometimes people really can't remember what's going on. We also see that there's severe insomnia or the exact opposite, hypersomnia, meaning that you're sleeping 16 hours or more in a day. Hard to wake people up. And often in tune with the insomnia, some people will have a reversal of their sleep pattern. So they're up all night and then sleepy during the day. The other symptom set is that we see social withdrawal. We see loss of those milestones that we were talking about. We see inability to perform daily living. So somebody who's been toilet trained since 4 all of a sudden is having accidents over and over again. We see decreased eye contact, almost like what you would see in somebody who has autism. We see rigidity around routines, so also called extreme inflexibility. And we see stereotypy or repetitive motor behaviors. I'll show you some videos of what that looks like. Some of our patients will have new focal neurologic deficits, meaning they're weak on one side or their face is looking different to you. So those are always ones we want to get worked out very quickly. And then we also see catatonia or muscle stiffness, and I'll show you some examples of what that looks like on the next slide. We see bradykinesia or slow movements. It almost looks like these people have Parkinson's disease at some points. And we see gait disturbances. So patients are unable to walk well as they previously were. The last two symptom sets, so we see a lot of language deficits. Sometimes this can be whispered speech. So all of a sudden you have a very loud and boisterous young person with Down syndrome who is now talking very softly, or if they can even get the words out. We often see that there's a drop off in the language that they're using or their ability to follow commands. So that receptive language where you're asking them to do something and they can no longer understand what you're asking them. Many of our patients will develop full mutism, meaning they're unable to speak or comprehend at all. The psychiatric symptoms can be very nebulous. Sometimes it's just anxiety or extreme fear about situations where they didn't really have any issues before. Sometimes it's delusions or hallucinations, which can be very scary. We see obsessive compulsive tendencies where there weren't any before. And in our young males specifically, but sometimes our female patients as well, we see aggression and agitation. This can be pretty severe in some situations. And obviously, when we combo that with extreme flexibility and anxiety, that agitation and aggression can be directed at parents who are trying to break them out of these routines. So these are 3 examples of catatonia, and I'll play the videos for you. On the first one over here on the far left, this young man, if you just put him into a uncomfortable position, he maintains his position in that phase for sometimes minutes at a time. Sorry, I think I froze there. Can you hear me now? Okay. So I'll play the second video over here. I'm just going to go on a more smaller stage so that way my computer doesn't stop again. You'll see in this middle slide here, this young man has lost about 40 pounds because he can't feed himself anymore. And very similar, he has a very stooped posture. And you put him in an uncomfortable position and he really can't move out of that. The same thing will be seen on the far right over here. This young man you place into a very uncomfortable position, and he's just kind of stuck in that position. But you can see not a lot of eye contact, not a lot of movement otherwise. Okay, so we also see repetitive mannerisms that weren't there before. So sometimes this looks just like autism. It would be what you would expect in somebody who has autism, but the key feature is autism doesn't develop over a period of days. It is usually very evident over time. So this is the repetitive behavior that you'll sometimes see that just kind of comes out of nowhere. And then our young woman on the far right-hand side, we'll show this. She just does this repetitive behavior over and over again where she's kind of touching her hands and she just does this all day, every day. We'll show an improvement video on her in just a bit, but that's essentially all she can do. And the key feature here is when you try to break that behavior, when you try to stop her from doing it, she gets very aggressive with that. We also see the response to internal stimuli. So this is a young woman who's sitting in a room all alone. Nobody's talking to her, but she's kind of smiling and interacting with things that may or may not be there. This can be laughing, this can be crying, this can be smiling, grimacing, all without any prompt in the environment. We also see a lot of emotional ability. So we go from happy individuals with Down syndrome who are doing a nice little dance to the extreme of that, just very upset, agitated, holding your head, unable to communicate what's going on around you. We also see that there's this dissociation. So many individuals with DSRD will exhibit a dissociated or apathetic phenotype where they're just kind of, again, off in their own world. Interestingly, some will start writing or speaking out topics that are totally unrelated to what's going on around them. So I include this image on the far right. This is a young woman who had lost the ability to speak, but was writing in page after page of a journal about Jesus and how he was coming back to save their family. And this is somebody who is really not religious, did not go to church, right? So it's just this kind of disconnect with what their typical daily functions are. We also see disorganization of thought. This is a timeline of the Civil War that was done by one of our individuals who was affected by DSRD. Beautifully written, dates, times, all of that. And then over a 6-month period, you can see the deterioration in the handwriting and deterioration in the thought process. And I think that this is just a good visualization of kind of the multimodal effect that's happening in these individuals with Down syndrome. So when we identify these patients, obviously these symptoms are very concerning. You should go see your doctor for it. But we have to figure out what this is. And so we recommend a very broad workup that we'll go through. But I wanted to include that last line in this slide is that at present, regression's a diagnosis of exclusion, meaning we have to rule out all of the other common things that can affect people with Down syndrome or could cause similar symptoms. And then we reach the diagnosis of DSRD as opposed to saying that that is likely the diagnosis right up front. So how do we do this? We have to get a lot of tests, and this is always the bummer. So the easiest things to do are just to get some blood work. So this is to rule out metabolic causes, gastrointestinal causes, nutritional, infectious, some inflammatory things. And I think most individuals, by the time they're reaching their teen years, have had a lot of blood work. They're usually seasoned pros at getting that done. The next 3 tests are a little bit more difficult to get sometimes. So an MRI is basically taking a picture of the brain, and it helps to look if there's a structural cause for the symptoms. So sometimes we can find inflammation, sometimes we can find stroke as a cause, etc. An EEG is a non-invasive test that we put little electrodes on top of the head. It doesn't hurt, and the patient wears a cap. And then we look at the brain activity to see if there's seizures that could be causing the symptoms of this. And finally, the most invasive test of the group is a lumbar puncture, which is called a spinal tap. And this is really to determine if there's inflammation present or not. This is the most important test, though. So the reason why I have to do the lumbar puncture, the spinal tap, is because when we take blood from the body, I can't actually tell what's going on in the brain because we have this blood-brain barrier. And that's a good thing normally, right? Every time we get infected with a virus, we don't get meningitis because that barrier keeps everything out. But it also prevents us from getting the right testing. So we have to go past that barrier with the spinal tap or the lumbar puncture to get that information. And the timing of the testing really does matter. This is a paper that we published a couple months ago that shows really after the first 12 months of the symptoms, the ability to detect any of these abnormalities goes down quite a bit, especially on the lumbar puncture. The only thing that is a little bit different is the MRI, and I'll show you why that is on the next slide. But I think that this is an important slide for me because if you're starting to see these symptoms and you're not sure, the default should be that you want to get tested pretty quickly because there's going to be a higher capture rate if you can get things done very soon. When we do the testing, so on the blood work, there are a few things that come back here and there. And this is a very medical slide. It's not meant to be, screened through and interpreted, but there's nothing really specific or sensitive in the blood. But when we get MRIs of patients, we see these spots. And I highlighted those with the little yellow arrows, so you don't have to be a radiologist to know what you're looking at. But those white dots are a little bit too big to be nothing and a little bit too small to be like a classic lesion that we would find in somebody who has like multiple sclerosis or another autoimmune brain disease. We also see that there are these dark spots in the middle of the brain. These dark spots are in a part of the brain called the basal ganglia. And you don't have to remember that necessarily, but this is the motor initiation center of the brain. So when I showed you those videos of those young men who are having a lot of difficulty moving, this makes a lot of sense because if we're having an injury to the motor initiation center of the brain and the patient is having problems initiating movement, this actually tells us a lot that what we're seeing on the brain matches up with what we see in terms of the symptoms. And when we compare those dark spots to other people who have Down syndrome, it's 30% versus 8%. So there's something different about people who have Down syndrome regression disorder where they're more likely to have those spots. And very interestingly, and just highlighting this again so you can kind of see what I'm talking about, when we look to see, well, what do those patients who have these dark spots do? They're 8 times more likely to respond to immunotherapy. So that tells us that these spots in the brain likely are inflammatory because if you have them, you're more likely to respond to the treatments that we offer on the back end. And I'll show some additional slides on that. So this is kind of more of a health awareness slide than anything, I suppose. But our job as doctors is to arrive at the most likely explanation for this. And some people it may look like Down syndrome regression disorder, but it was actually a thyroid disorder. It was actually some other type of stressor. So you have to let the doctors kind of figure that piece of things out. But we have to encourage discussion. We have many families that go and they may evaluate get evaluated and they feel frustrated after the evaluation because there doesn't seem to be a cause. Or the doctor says, I don't really know if it's regression. Let's just give an antidepressant. This looks like depression to me. But it's okay to ask for, additional information. What's the timeline that we're going to try this, etc. Very similarly, in that yellow area, if a therapy is not working or it's only giving partial results, it's okay to ask your doctor why. Should we be looking at other options? Should we be trying a different treatment? I think this is a really important thing that sometimes we get stuck in, accepting inferior results. And the last thing to remember is the medical community is still learning a lot about this. I feel very old. We just had our third kid about a month ago, but in reality, we've only been actually researching regression in earnest for about 5 years. So we've discovered a lot. We've made a huge amount of progress during this time, but we're still learning, even on an every month basis, what is new in regression. So you got to give, some flexibility to doctors that you're working with as well. So the next question that logically comes up is there a treatment? And the answer to that is there's not one singular treatment, but I'm going to show you some of the information. It'll get a little bit sciencey, but I'll explain it as best I can about what the best options are. But I think that the most important thing is many patients are on different types of therapy, some for symptoms and some for treating the disease. So when we look at all the different types of treatments, right, we see that there's antidepressants, there's antipsychotics, there's benzodiazepines, which are used to treat catatonia and other psychiatric symptoms. And some of that we use because we thought it was psychiatric for a very long time, but some of it is because it actually helps with some of the symptoms. Very similarly, electroconvulsive therapy or shock therapy actually does work to treat the catatonia symptoms, but it does seem to be something that requires long-term use and can be dangerous to people with Down syndrome. The cholinergic agents are actually Alzheimer's medications. They don't tend to work very well, but there has been a few patients that have had some benefit from it. But what I'm going to focus on mostly, because my background is as a neuroimmunologist, is the role of immune treatments in the management of this syndrome. So this is a very busy slide. So I included a little red bar to help us focus on what we really need to. Way back when, in 21 and 2022, we looked at what was the rate of response to immunotherapy overall. And if you had a diagnostic abnormality, your overall response rate was about 74%. But what I'll draw your eyes to is that line two below that, where we see that the overall response to IVIG, which we'll focus on in the next slide, was 92% and 82% respectively. And this is really important because IVIG is not a treatment for psychiatric disease. It's a treatment for autoimmune and inflammatory diseases. When we go a little bit further, so we look head to head, the squared lines, so we want lower scores on these particular measures. So the faster you go down, the better you're doing. And those squared lines are IVIG. The black bar at the top is if we do nothing over 6 months. Obviously, we're almost never recommending nothing. And then that middle line with the triangles is lorazepam, which is a treatment for just the catatonia. So it only treats the symptoms, it doesn't treat the cause. And I think you can see without any additional numbers, on pretty much every metric, we're seeing that the IVIG or the immunotherapy beats out the doing nothing and kind of just the symptomatic treatments over and over again on all of these different subscores of the disease process. So when you get on the treatment and it's working, well, how long do you need to be on it? That was kind of our next question. So we took our first 82 patients. We've gone on to evaluate about 750 patients at this point. But our first 82, we weaned them off of IVIG after about 12 months. And we found that it was basically 50-50. Half the patients didn't have to be on treatment long term, and we kind of fixed the problem. And the other half had their symptoms come back when we tried to take them off of the therapy. And you can see that in the ones on the bottom line, that black continuous line, if they got better and we took them off therapy and they did well, they actually continued to get better even off the treatment. Whereas the ones that didn't, and that's the dash line, they basically went back to where they were before. And some of this makes a lot of sense, right? If you have lupus or you have Crohn's disease or, asthma, and you come off your medicines, you bet your bottom dollar that you're going to have a relapse or an attack that comes back again. And when we're thinking about things as autoimmune, we think that some of the patients that actually responded and we were able to take them out, we just caught the disease earlier and treated it faster, whereas the ones that relapse have now developed a chronic condition. Just one more highlight to say, like, the faster that you get evaluated, diagnosed, and treated, the better you're going to do long term. I like to include this slide because I think it's really clear what the difference is on treatment versus off treatment. So the names of these two tasks, the NEPSI, this is from our colleagues in Colorado, is basically the instructions are draw a line between the car and the flag or the motorcycle and the flag. The motorcycle one being the harder task because it's longer. And you can see that in the first set where the patient is not on any treatment, she doesn't really follow the rules. She just kind of colors in the boxes. Week 16 is on treatment, and you can see that she does the task no problem, right? It's pretty much a straight line to the finish line. And then at week 40 off the therapy, you see that she goes back to what she was doing before, just kind of coloring in the boxes, not following the rules with this one. When we look at second line immune therapy, so in people who have failed IVIG, right, or had a suboptimal response to IVIG, oftentimes we'll do immune suppressive therapies after that. And this is brand spanking new data that we have that's in review right now. But if you look at that post-immune suppression group, right, everybody has the same baseline, everybody responds the same to IVIG. But then if we add in additional immune suppression, patients still get better after that. And so the green bar is B cell depletion or rituximab, if you've ever heard of that. This is actually a chemotherapy that has been repurposed and takes away the body's ability to make antibodies. The orange or the red, depending on if you're colorblind like me, line is tofacitinib or a JAK inhibitor. JAK inhibitors lower the immune system more globally, and we think are more specific to people who have Down syndrome because they have upregulation of the JAK-STAT pathway, which is affected by tofacitinib. And the blue bar, which still shows improvement, but just a little bit less, is something called mycophenolate mofetil or Cellcept. Cellcept is actually a medicine we use in people who get transplants, like a kidney transplant, but we use it because it's very gentle on the immune system. It lowers it down just enough to actually have a clinical benefit there. But this is a study that we have in review right now, so we're still waiting on some feedback on it, but this is something that's hot off the press. We also have a clinical trial that's running at the same time. I can't share any of the new data on that one, but we are finishing our enrollment probably in the next couple of weeks, and we're hopeful that our colleagues in Colorado will finish soon after that. And that'll be actually the first clinical trial in Down syndrome regression disorder, with the hope that we can move towards a phase 3 study to get FDA approval pretty quickly thereafterwards. So we're moving at, lightning speed right now from that standpoint. I'll share one video. I think that this is one of my favorites. It just highlights really well the before and the after in Down syndrome regression disorder. So I'll just play this very quickly. You can see just the dramatic difference, going into the regression. I think that if you think about those, middle slides that we were showing, it almost looks like if you had never seen her, you would guess that she just has autism spectrum disorder. But then those post videos are really just weeks after receiving IVIG, which was really encouraging. She's doing great now. I've included our slide about our symposium in September. I think it'll be a lot of fun. It'll hopefully get a lot of people in the LA area, plus the rest of the country too, to be all together in one spot, meet the experts. It's designed to give everybody the latest and greatest up-to-date information. We'll have speakers from UCSF. We'll have speakers from University of Toledo, Dr. Eileen Quinn, who runs the Down syndrome regression disorder Facebook group. Dr. Sanar will be coming from Colorado. So it'll be a great experience. And then we'll have a little reception on the house for CHLA so that families can get to have a kind of a social interaction afterwards. For those of you interested, all you have to do is take your phone real quick, point it at the QR code with the camera on, and then it'll upload the link and the instructions there. So I'll leave it there for a moment so everybody can just take a camera shot of it. Or you can use the link that I've provided down at the bottom. But this year it's being supported by the National Down Syndrome Society, which is a lot of fun to partner with them. Cabo Fusion, who helps us a lot with um, our infusions for IVIG, and then the Howland family, who was one of our original participators in our clinical trial, which was really exciting. So I'll leave that up for one moment, and then on the next slide, it'll include our email if you have any questions or want to reach out to us as well. And then with that, I can take any questions or comments or things from there. My only request is I can't give specific advice, medical advice on a Zoom call, but I'm happy to answer any questions I can. But thank you very much.
Somebody was asking if the YouTube videos had sound because nobody could hear the sound, but I don't think they did.
Oh, okay. I will find a way we may be able to just give you guys the direct YouTube link for that, so I apologize.
Mhm.
I have a question. Can you hear me? This is
Yes.
Dr. Santoro. A lot of these symptoms, my daughter's 35. I'm not seeing any of these symptoms, thank goodness. I'm just wanted
Yeah.
this background, but they seem so Parkinsonian. And I know you mentioned that. Has there been any study with some of the Parkinsonian drugs with some of these patients?
Yeah, it's a great question. So there's not that there has been a great study for it, but anecdotally, we've had many patients try Sinemet, which is kind of the go-to Parkinson's drug. Very rarely is it having an effect. And the reason for that is that MRI that I was showing you, it's actually just in a slightly different area of the brain that's getting impacted. So the basal ganglia has the substantia nigra. This is very medical, but the substantia nigra within it, but it's like right next to that area, so it's not quite causing it. And I think that that's why we're not seeing the improvements with the Cinnamon.
Thank you. Yeah.
I have a question, doctor.
Yep.
Are there any negative side effects, both short-term and long-term, to the immunotherapy treatment?
Yeah, great question. So with IVIG, thankfully, there's not a lot of side effects. So most patients, because it's an immune boosting medication, will not get sick at all, really, while they're on the treatment. The side effects of the IVIG are kind of the big three. So one is it's a blood product, so it can cause an infusion reaction or an allergic reaction. So whenever we get the infusions, we have an emergency reaction medicine kit available for every patient. The second thing is it can cause a really bad headache and something called aseptic meningitis. Sounds a lot scarier than it is, but basically it's a body's chemical reaction against the IVIG. We see that very, very rarely, like incredibly rarely. The one that we have to monitor for the most is clotting. So with any immune treatment, including IVIG, long-term use can increase the risk and predisposition to developing a blood clot. Usually there's going to be deep venous thrombosis that develops in the leg, very common, but if they're not detected early enough, they can travel up to the lungs. So we try to get patients off of birth control or any other medications that could increase the risk for clotting before they start on the IVIG. For the immune suppressive therapies, there's many different side effects, but most of them are either clotting or because they're suppressing the immune system, infection. And those are the ones that we worry about. That's with the rituximab, tofacitinib, and the mycophenolate mofetil or CellCept.
Thank you.
We have some questions in the chat. I think is there an age where regression starts? Okay, it was in the.
Yeah, so it's a great question. So we say most regression is going to start between 10 and 30 years. Young girls or female patients seem to be a little bit younger. So it's kind of like 12, 13, 14, 15. Young men to be a little bit older, 17, 18, 19, 20. I think our youngest convincing patient was 4. Our oldest convincing patient was 42. So it's a wide range. And I don't think we understand a lot about what the difference is, based on age. People seem to be similarly responsive to treatments, regardless of where they are. The biggest thing is you got to get diagnosed early because that's the only thing that limits the effectiveness of the treatments is if you take too long to get diagnosed and treated.
Can I ask, one of the questions that I asked Dr. Santoro offline is if there was an age limit that he says, because I guess somebody told the parent that he only saw adults 30 and under.
No, we'll see pretty much anyone. So if there's a need, we'll always see a patient. We are having a nurse practitioner start up with us in August to give me a hand in clinic because it's we're getting a lot of patients, both from Los Angeles, California, California on the whole, but also around the country. So we're hopeful that in the future with, if funding priorities at the NIH and a couple of the other federal organizations changes, we'll be able to get some funding to help train additional doctors in Down syndrome neurology so we can start to sprinkle them across the country too.
I have a question.
Go ahead.
Can you hear me?
Yes.
Okay. Okay. I would say 4 days ago, my daughter on Wednesday, started complaining that she wasn't feeling good. Her body temperature she's always hot. So, but the thing is that she's like starting poking her eyes, and she doesn't want to eat by herself. I have to feed her. If I don't feed her, she will not eat. If I don't give her water, she will not drink water. And actually, she's by my side. I have to hold her hand all the time. And I don't know if that has some, I have to like get her dressed, do everything for her. So I'm afraid that it might be the regression disorder. And I try to call different doctors, and they don't see patients 23 years old. She needs to be 20 or 30. So, and that's what I'm dealing with right now.
I'm gonna include our email in the chat. Just email us and we can help you out.
Oh,
But yeah,
great.
we
Thank
want to
you.
get her checked out, Martha, so that way we can see what's going on for sure.
Okay, great. Thank you so much.
I have a question.
Go ahead.
Yep, go for it.
Okay, I guess it's more personal, so if I can't ask these questions, let me know. I have a 32-year-old daughter with Down syndrome, and I suspect that she
Oh,
has this regression, and but I looking back now, I'm only familiar with this regression maybe the past 8 months. And so I think it started during COVID. So it's 5 years already. And I know you keep saying, well, you've said that timing matters to try to catch the regression and to get
pronto.
treatment as soon as possible. So what would can she still be helped if it's been 5 years?
Oh yeah, definitely. So here's what I'll say is the best treatment window is before 2.5 years. But we've still seen patients a decade and a half after the onset of the symptoms still get better. It may not be all the way better, but if it's been going on for 5 years, we can definitely help with some of the symptoms and certainly help try some of the immunotherapies. I think that the just important thing is to set the expectations that it will be harder to treat, but that doesn't mean we should not treat.
Right. Okay. And so I am going to the symposium, my
Hmm.
husband and I have been emailing with Lena, one of your nurses at on your email.
Yep.
And she sent me an outpatient referral form, which I sent back. And I was told, I think you're booked till next year. So in the meantime, should we do anything? I mean, what can
So
we do?
yeah, we're so the wait list right now is long. I'm only one person, but
Right.
that's why we're adding on the nurse practitioner, so that way we'll be able to evaluate and triage things a little bit faster. So I'm actually hopeful that we'll be able to get you off the wait list a lot sooner, but right now we're backlogged until August. So, but
Okay.
we'll keep in touch.
So what do I do in the meantime?
Yeah, I mean,
Any
if
suggestions?
where are you based out of?
Hawaii.
Okay, have they seen?
ABCD.
Yeah, have they seen a neurologist yet or no?
We're going to see a neurologist, but I don't have any doctor here that is familiar with
Yeah,
Down syndrome regression.
yeah.
That's my problem.
Hawaii is a tough place right now, but
Yes,
what you can do is if you ask Lena for all of the papers and documents, that's things that you can actually give the neurologist
I
locally.
did.
Because yeah,
Okay,
perfect.
I
Because
got
that
all
actually
of
goes a
that from
long way.
her.
Yep.
Okay, I did get that paper from her already.
And then if you share that email that I included in the chat with the doctor, they can reach out to us directly, and I can get on the phone with them and talk them through it. So that way you've got at least the appropriate evaluation and steps before, any additional workup.
What is that again?
It's the DS research at chla.usc.edu. It's right in the chat if you pull it up.
Oh, okay. Okay, thank you very much.
Of course.
There's another question. What insurance is accepted to be seen with you guys?
Yeah, so I don't have the full list, but at CHLA we pretty much take everything. We're an encatchment hospital, so with very few, circumstances, unless you have like a UCLA specific insurance or something like that, usually we can see you. So Kaiser and UCLA insurance are the exceptions, but otherwise we can see pretty much everybody.
Kaiser, and what was the other one?
If you had like UCLA has a very
Mhm.
specific UCLA only insurance, but that would be the only other one that really we have problems with. And we can even help if you have Medi-Cal as a secondary insurance. Sometimes we can get that approved as well.
The Presley family have a question.
Yes, I have my daughter is
Dr.
55. Yes, my daughter is 55, and she has been showing all of the symptoms that you mentioned for, I think, since probably the pandemic. And I've taken her to a neurologist, and he did an EEG. He treated her for a year with B12, and he just kind of dismissed her after that. So we're kind of in limbo right now. We don't know where to go. I think I've heard about, UCLA LA program, but it's so difficult for me to get over there.
Hmm.
Um, so is
Where are
there
you guys
any,
based out of?
we're in Pasadena and Altadena, actually.
Okay.
So,
Um, so I think that the biggest question that we'll have in that age group, right? Because if we're talking about 55 now, pandemic kind of starting, at 50, our rates of dementia do start to kick in. So people with Down syndrome are also at risk for Alzheimer's disease. But the only
right,
way that you're going to figure out if that's the cause or not is to actually do the testing to prove it one way or the other. We can certainly help you out with that, or I can help, if you email us on the DS research line, I can route you to the Keck team as well, which will be a lot closer for you guys from Altadena.
right. Okay,
Yeah,
okay.
but we can help you
Yes,
out with that.
because he prescribed, he diagnosed her as having dementia and prescribed donepezil,
Yep.
which I just stopped. I stopped giving it to her. It wasn't really. I saw no benefits really in doing it. And when she went for a physical and had a blood work done, it showed that she had some enlargement of the liver and a cyst on her um, a kidney, a right kidney. And so I'm thinking it could have been from, I looked up, donepezil, and I'm
Yep.
thinking, because she doesn't take any other meds, really. She doesn't take
Yep.
anything. So I stopped giving her the donepezil because of that. It was just a useless drug and seemed like it was causing more problems than anything else. So,
Yeah, and I think that really warrants maybe a little bit more of a workup and evaluation. But if you email us, we can certainly help connect you with the Keck team. And if they say, hey, this doesn't really look like dementia or we need a workup for regression, we'll get you guys in. That's not a problem.
okay, I appreciate it. Thank you so much.
Another question in the chat is what about a person developing type Bs, but not showing other regression?
Yeah, so if there's just the stereotypies are present, then it's probably not DSRD. But there may be other causes for it. So stereotypy increases can be associated with a lot of metabolic changes, like thyroid dysfunction, things like that. So it'll be a more abbreviated workup, but definitely still want to get it checked out by a neurologist or a psychiatrist.
We have Vicky. Is it Vicky?
Hello. Hello.
Yeah, Vicky?
Yes, we can hear you.
Yes. Hi, Dr. Santoro. How are you?
Good. How you doing?
Well,
I don't know if you remember Brandon. We came to see you last Valentine's Day.
Of course.
Yeah. Let's see. My question really specifically, if you don't mind, real quick. Like the past 3 or 4 months, he's really gone really downhill, almost 180. It's he's had next his 4th dose of IVIG, and his aggression has just been turned pretty much into violence at his ADT program, striking at the workers and whatnot. And I'm just at a loss of what to do. I don't know any ideas. I haven't given you much information, but yeah, he's the one here in Clearwater. We got him started in May, and then he went like 7 weeks without because of insurance, and then it got started again every 4 months. So, like I said, next week will be his 4th infusion. Is there like a big some kind of something that majorly happens at this time, or how do I deal with the negative effects, or can I assume it is from the infusions or his medications, or what do you say, suggest? I've been speaking with Dr. Mahmood.
So Vicky, I'm not able to. I think my Wi-Fi is breaking up, and I can't hear the entirety of the question. Give me one. Let me just see if I can get. Sorry, 1 second. All right, can you try to repeat that so I can try to hear it? I'm
I
very
think
sorry.
Vicky's connection, because there was stuff parts that I didn't hear either.
Okay, repeat from where?
Just a question, not the story or.
Yeah, I'm sorry. Let's see. I've been working with Dr. Mahmood, the Down syndrome clinic in Orlando. He's working, through you. I just didn't know if there's something that I should be expecting from the treatments as far as his total aggression so soon.
Okay.
Maybe I'm not making sense.
I'm sorry, I can't hear anything. Vicky, if you want to email me, I can reach out to you guys directly. I'm sorry.
Okay.
Let's see if anything else in the chat that we can. We only have a few more minutes.
Excuse me.
Oh,
Can you put I'm sorry. Can you put the email for Dr. Santoro again? Because I didn't get it.
that's right. I just added it right now.
Oh, okay, great.
So
Thank you.
someone said that her husband passed away 4 years ago. The daughter misses him a lot, and she's talking to herself. Could that be a regression?
Which one?
Well, I think we lost Dr. Santoro. Thank you. Maybe he was having issues, and I thought it was Vicky's thing because she was also cutting out. We'll wait and see so we can. Thankfully, it's towards the end of the presentation. Let's see if he comes in again.
Mhm.
But I added the email in case you guys need to get in
Is he
touch.
done?
Something because I wanted to. Okay, there's Dr. Santoro again.
Mm.
All right, guys, I'm trying a different computer instead. Sorry, I was not able to hear almost anything.
Yes. Mm.
It's the question in the chat about I guess it was her husband passed away 4 years ago and her daughter is talking to herself. Could that be a regression?
I mean, it could be. It's a little bit harder to know if there is no other developmental regression. Depression and stress could be a cause for it, but I'd still say it's worthwhile to get checked out. Has she been diagnosed with depression or no? Or tried any treatments for it? Yeah. So it may be worthwhile to get checked out with that one. But yeah, I mean, it's tough because there's a lot of people that have one or two symptoms of regression, but not any of the other ones. And I think that that's where it becomes a very nuanced diagnosis by the doctor. But there are diagnostic criteria that are available online. So if you look at the National Down Syndrome Society website, we help them develop a checklist. So if you actually pull it offline, you can actually go through and kind of check off the things that you think your loved one is experiencing, and that can often be helpful for making that determination too.
Great. I feel like, well, I know a few individuals, adult individuals that have shown a lot of regression, kind of what you explained, and we didn't know anything about regression until the last 5 years. So they've had it for like 10, 12 years. Is that can they still get or improve their?
Yeah. So they, I think it's always more challenging the longer that the time period is going on. But I would say that that would be true of any medical condition. But I think our oldest patient is 15 years out from the onset of her symptoms. And we enrolled her to our clinical trial, and she's still responding to therapy 15 years out. Now, it's not the most robust response, but it goes from basically having their parents sit with them 24/7 to being able to have her go to the bathroom independently and eat a sandwich without prompting anymore. So, right, those little functional improvements, it may not sound huge, but like that's a huge difference in terms of the family dynamic as well. So we always talk in our clinic about what would be meaningful things from the baseline. And if it's, I just want, little Johnny to look me in the eye, right? I mean, those sometimes are really important things, right? Regression robs the personality, the spark that makes people with Down syndrome so special. And I think that really when we start to see any improvements, I think we're all generally happy. But our goal is always to get people 100% back. That's what we're always looking for. That's why we continue to do, as much research. And I keep getting gray hair because we've got a lot of, we've got a lot of room to make up because we've been kind of sitting on this for 80 years. So
one question. We hear a lot about, COVID, of course.
Yeah.
How a lot of our kids show a lot of regression because of COVID. And is that something also that can be seen, or is just the explanation is COVID? And I'm not sure how, we can go about it.
Yeah, so it's interesting, like, right? I mean, people without Down syndrome were regressing during COVID. I mean, everybody was impacted by this. So we saw a lot of people who were impacted. It's interesting is that I would say the minority of people with Down syndrome were very negatively affected because a lot of the time the world got a little bit smaller. You were spending extra time with your family and caregivers. But for those that were a little bit older, especially after high school, that routine becomes very important during the day. And as soon as you break up that routine, a lot of people were kind of falling through the cracks, right? I think we all figured out pretty quickly online physical therapy, speech therapy, occupational therapy just didn't cut it.
Doesn't work.
Right. So, I mean, it sounded good in concept, but it just never worked for the vast majority of people. Many individuals who had regressed during that time got better. But there were a few that had organic Down syndrome regression disorder just happened to start during that phase. One thing I can say with confidence, though, is COVID and the COVID vaccine very rarely, if ever, triggered DSRD. That never seemed to be a consistent pattern for us in our research. And even as we're looking at like antibodies against COVID and all of that, we've actually found that people with Down syndrome are much lower than everybody else in terms of overall response to these things. So I actually don't think that that particular virus was immunogenic in the way that it would cause Down syndrome regression disorder. Certainly people were getting sick because of COVID at the time, but we've never found any real pan out from there.
Okay, and let's see, do you guys have any last question, or we can go to the chat? In the chat, I don't think that Dr. Santoro can tell you how much is an evaluation, if it's out of pocket.
Yeah, I don't know. We have a whole office that does that. I would generally recommend not doing it because the CHLA is a hospital and they're always trying to make money. We can find alternative ways if that's going to be the situation, but I almost never recommend doing them. Like even if I'd rather do it for free and talk to your doctor and take them through all the different steps than have you guys pay out of pocket. That's just ridiculous. We want to help, but I don't want you to pay anything.
So we are recording this session. If somebody came in a little late, you can always go to the beginning of the presentation when I put it on YouTube. Because some of the questions that I see that were addressed during the presentation. So thank you so much, everyone. I think that we're pretty much done. Thank you, Dr. Santoro, for joining us. You're always so very kind with us, and we really appreciate it. Thank you, everyone, for waking up and joining the presentation. I think it's all interesting, you know, because I also see some stuff with my own son. So, and they're asking if we're gonna share the presentation with us.
Yeah, and I can also send the PDF to you, Sandra, so you can send it out, because I think that will have some of the more defined things, and I'll just take out the videos because you won't be able to see that on a PDF. But I hope to see many of you. Thank you, Sandra, for hosting this, and I hope to see many of you in person in September. You know, we're a small and very lucky community in Los Angeles and in California, and I think Sandra is the cheerleader for a lot of that in Los Angeles. So thank you all, and looking forward to seeing you all.
Everyone, and
Thank you.
Thank you very much.
Enjoy the rest of your
you.
weekend.
Thanks a lot.
Okay, thank you.
Thank you so much.
Bye.
Bye.